Hello and welcome you all to our podcast series by PACESDIARIES.UK. This podcast series is focused towards catering all the necessary information about MRCP UK and MRCP Ireland PACE examination for those who are preparing for PACES and also for those who wants to know what MRCP UK PACES is all about. I'm your host Dr. Sophia ALDRINE, and today I'm here with another important topic to discuss in neurology with none other than our very favorite Dr. Moses J. Wesley. So, Doctor, welcome to our podcast series today.
Thank you so much. It's such a great pleasure and honor to be here in another podcast series where we are dealing neurology for PACES in our neurology podcast series from PACESDIARIES.UK. Thank you so much.
It's a pleasure to have you today again with us and to discuss another important topic in neurology. So today Dr. Moses will guide us through a very, very important topic, that is Parkinson's disease. This is one of the most easiest topic but can go wrong terribly if a candidate isn't well prepared. It's one of the most common cases that can appear in PACES. It can be kept in a neuro station as well as in the consultation station. We have also seen in communication station where management of Parkinson's has to be discussed. So overall, it needs like extra highlights. Let's get into the discussion about this topic. Just like our previous topic on myasthenia gravis, approach to Parkinson's is quite different as well. So doctor, can you guide our candidates on the examination sequence of Parkinson's disease?
Oh yeah, it's extremely important. Like Parkinson's examination sequence is very peculiar. Candidates who don't know that, they will fumble, they will stumble, and many of them make a big mistake by watching some online videos or listening to some mentors who tell them, don't walk the patient at last. Don't do that. Parkinson patient, the money is on the gate. If you don't establish the gate, you're gone. I'll tell you the sequence. All right. Again, the sequences of all the important clinical cases are available in our PACESDIARIES.UK website. And here we go. You enter, you're going to go ahead, sanitize your hands, wish the examiners, wish the patient, talk to the patient and introduce yourself. I'm Dr. Moses. I'm one of the PACES candidate here. I'm here to examine you. Is it all right with you? Are you comfortable right now? While you are talking, notice hypophonia. Number one, also look around the bedside. Any walking aids, anything is there in the bedside. Done. Then the very first thing I want any candidate to do is gait. Walk with the patient. Start with the gait. Look for stooped posture, reduced arm swing, en bloc turn. All right, please walk close to the patient and never ever pull patient and try to do any postural instability. You are not required to do that. Just offer to the examiner at the end. All right, then make the patient sit. Let us divide into face, hands, and legs. So what you have to look for at the face, look for masked-like faces. See behind the ears. Why? Parkinson's disease is associated with seborrheic dermatitis. Glabella tap, it's not needed. All right. Then ask the patient to close the eyes gently. Gentle closure of eyes. You can find a blepharoconus. Then check for the eye movements to rule out progressive supranuclear palsy. And also you can notice any nystagmus if there is any cerebellar involvement. Okay, come to the hands. Keep a pillow. Look for asymmetrical tremor. If tremor doesn't comes up, give an arithmetic stress, like ask him to do a count of 5, 10, 15, 20, 25, 30, 35, 40, like that. All right, then check for rigidity. If rigidity you are not able to elicit, do synkinesis. That is, ask him to move the other hand up and down while you're checking for cogwheel rigidity. Then check for bradykinesia. Ask him to close and open the fingers. All right, then you can give a piece of paper and a pen, check for micrographia. All right, then you can ask him to close the eyes, and in the hands, you can just write a number. For graphesthesia, you can write number 8, 7, whichever you like, This is to rule out corticobasal degeneration, because graphesthesia, 2-point discrimination, and astereognosis are your cortical sensations. All right, and then do the cerebellar examination, finger nose test, dysdiadochokinesia. Then ask him to tap the hand and the foot. If the bradykinesia is more in the lower limb than the upper limb, it is a vascular Parkinson's. Once you have done that, you have to turn to the examiner and tell, I'd like to check this gentleman's cognitive assessment, the cranial nerves, lying and standing blood pressure to rule out multisystem atrophy, examination of other cranial nerves, and of course, postural instability. You do it right, you'll be fine. Just try to repeat this sequence even on a normal patient multiple times. So when you get a Parkinson's patient, within 5 minutes, you'll be able to do it. If you do it properly, if you are just practiced it multiple times. All right.
That's a very wonderful discussion about the sequence, doctor. Thank you so much for that. There are a lot of videos online regarding Parkinson's disease examination, but the one that you mentioned right now, the top-down approach, it's much more easier, it's clear, and it's not very confusing for any candidate to remember, recall, and do it in a systematic way. It won't go haphazard and confuse the candidates as well as the examiners. This is a very clear approach, what you said. And I'm sure if our candidates follow this, they'll definitely be able to crack this station for sure. So it's not just enough if a candidate knows what Parkinson's disease is all about. For PACES, one should be familiar with the classification of Parkinson's disease as well. So, doctor, how do we classify Parkinson's?
All right. The most common case we are going to get is an idiopathic Parkinson's disease. That's the most common. Then comes the secondary, that is an acquired cause. What can cause? Drugs. A lot of drugs, including MPTP and some antipsychotic drugs. All right, all this can cause. Then some hemiatrophy of the brain can present with Parkinsonian features, and hypoxic ischemic encephalopathy, some viral infection, toxicities. All right, all these things can cause. Then comes your Parkinson plus syndromes. At least remember four: progressive supranuclear palsy, multi-system atrophy, corticobasal degeneration, and Lewy body dementia. All right, these are Parkinson plus. And one more hint here. If they ask you what are the causes of young onset Parkinson's, a young guy coming and presenting with Parkinsonian features, you have to rule out two things. Number one is a Wilson's disease, and number two is Japanese encephalitis. In both cases, young gentlemen can present with Parkinsonian features. Also, drugs like MPTP can present like that.
So, doctor, apart from the classification that we just discussed right now, any other cause of Parkinson that a candidate needs to be aware of?
Exactly. There are a couple of other things that can cause, like I said, the medications, like, this chlorpromazine, metoclopramide, prochlorperazine, your sodium valproate, methyl dopa, all this can cause. And any tumors of basal ganglia. And there is a condition called dementia pugilistica. That's like due to Box's dementia, due to chronic head injury. All right. They can present like that. Normal pressure hydrocephalus, post-encephalitis, and other toxins, like apart from MPTP, there's a carbon monoxide, manganese toxicity. All these things can present like Parkinson's.
Okay. One of the most important component of Parkinson's disease is tremor. So sometimes we see that the tremor, you can't notice it in a patient with Parkinson's, and candidates in that stressful situation, they just go blank. So, doctor, what are all the things that a candidate must know about the tremor in Parkinson's disease?
All right, this is a very, very important question. The thing I want to tell you here is just because you didn't see a tremor, or just because you didn't see a typical masked like faces in a PACES examination, doesn't mean the patient is not of Parkinson's. Because most of the patients you are going to get in the PACES examination are already on drugs. So you may not find all the classical findings. And I've seen even during my classes, and candidates coming and asking like, this features are not there, that features are not. It won't be there, doctor. It won't be there, I used to tell, because the patient is on treatment. All right. So what you have to do, always any hand examination, keep a pillow, ask the patient to keep his or her hands over the pillow and give an arithmetic stress, and the tremor will erupt. Typically, this tremor is present at rest, and it's an asymmetrical tremor. Typically, it is around the frequency of 4 to 6 hertz. All right. And remember, 20% of the patients with Parkinson's disease may never experience a tremor. Very important thing. The tremor can be a pill rolling motion. All right. Some patients may also exhibit a foot tremor or a jaw tremor as well, which I've shown in some of my classes. All right. The tremor can be, like I said, enhanced with some mental activity. All right. It can also increase with walking. That's why I tell people to notice the tremor when you walk the patient, even during emotional stress. Typically, during sleep, this tremor will go off. All right. And there is another thing, head tremor. Head tremor is titubation. All right. It's more in case of essential tremor than Parkinson's disease. These are some of the peculiar features of tremors in Parkinson's.
Okay, that's a very important topic that every candidate must know, and I'm sure that they have gotten all the important information regarding the tremor in Parkinson's. Another important concept that arises in this topic is difference between Parkinson's disease and Parkinson's plus syndrome. So many lose the station as they fail to differentiate between these. So, doctor, please enlighten our candidates regarding this.
Absolutely. That's a very, very important question. All right. So Parkinson plus syndrome is important. This I will just address two things: how to differentiate and what are some of the commonest Parkinson plus syndrome a candidate should be aware of. First thing, an idiopathic Parkinson disease is a progressively growing disease. Like it's not going to come over the night. All right. When it comes to Parkinson plus syndrome, it's a sudden onset. Next thing, an idiopathic Parkinson's disease, there will be a very good response to levodopa, where in case of a Parkinson plus syndrome, the response to levodopa will be extremely poor. And then in idiopathic Parkinson's disease, all right, the symptoms will be like, and even the distribution will be like more of asymmetrical, where it will be symmetrical in Parkinson plus. And in case of an idiopathic Parkinson's disease, there won't be much of Parkinson plus signs, where it will be there in Parkinson plus. So how we are going to identify that? Number one, progressive supranuclear palsy. All right. What are the key features? If you take, if you do investigation, you can find gliosis of, also neuronal loss, gliosis, and, neurofibrillary tangles in pretectal area, even substantia nigra. And the most classical feature here is patient will report of some falls and eye movement restriction will be there. Very important. Then coming to multi-system atrophy, it can present in various ways. It can present even as a cerebellar syndrome. It can present with some autonomic dysfunction, like that of an erectile dysfunction, and sweating disturbances, and some dizziness on standing. All those things it can present like. Okay, then comes your corticobasal degeneration, where there will be involvement of cortical sensation, which we have discussed. So these three are very, very important. Then comes your Lewy body dementia. So what's a Lewy body dementia? The classical feature is there will be visual hallucination will be there. And dementia will be there. And Lewy bodies, what are Lewy bodies if you take typically? Lewy bodies are spherical cytoplasmic eosinophilic inclusions. Remember SCE. It's not just limited to Lewy body dementia. You can find Lewy bodies in other disease as well, like your Haller-Walden-Spatz disease, your Alzheimer's disease, even for your Lewy body dementia as well. So these are different Parkinson plus syndromes, and the difference between a Parkinson's disease and a Parkinson plus syndrome.
This has to be the most simplified explanation to know the difference between Parkinson's and Parkinson's plus. So this is very easy to remember and also revise and recall. So, doctor, what are the complications of Parkinson's?
Okay, Parkinson's disease can lead to a lot of complications. So, couple of complications. The most important one recently came as a case in one of the center in South India. That's levodopa-induced dyskinesia, motor fluctuations, dementia. I think around 15% as per latest studies of Parkinson patients are prone to get dementia, constipation, bladder dysfunction, orthostatic hypotension, sleep disorder. Typically, many patients, the very first finding you will find is a REM sleep disorder, rapid eye movement sleep disorder. They'll act out of the dreams. Then dysphagia, psychosis, depression, anxiety, all this, and plus all the drug related complications. These are some of the complications of Parkinson's disease.
Okay. So, doctor, as we know, Parkinson's is a condition of clinical diagnosis. Are there any investigation that our candidates must know? And what's the plan of management? Like, how do we treat?
Exactly, I'll come to that. All right. So when it comes to Parkinson's, we use a criteria in United Kingdom. Okay, I don't know how many of you are aware of the criteria. The criteria is UK PD criteria. That is UK Parkinson's Disease Society Brain Bank criteria for diagnosis of probable Parkinson's disease. There are some inclusion criteria. Just you don't need to know everything. Just remember the cardinal features of Parkinson's: bradykinesia, rigidity, tremor, and postural instability. All right. So, how are you going to investigate a case of Parkinson's? Like I said, it's clinical, completely clinical. You can do dopa uptake scan, okay, a SPECT scan, and look at the dopamine receptor and see how the dopamine uptake is. And you can do an MRI scan, definitely. This is to rule out Parkinson plus syndrome. You can do some olfactory testing for hyposmia and anosmia. You can do serum ceruloplasmin if you want to rule out Wilson's disease or Japanese encephalitis in young patients. You may have to do other tests related to JE. And you can do some cardiac sympathetic study using MIBG, especially for, you know, Parkinson's disease and MSA differentiation. All right. There are some latest investigations have come. Now they're doing something called a skin biopsy. All right. In skin biopsy, there can be abnormal dermal alpha synuclein aggregates in case of patients with Parkinson's disease. Once again, I'm repeating, abnormal dermal alpha synuclein aggregates or deposits. This is seen in some Parkinson's disease. So these are the investigations a candidate has to know. Beyond this, you need not know or tell anything. Coming to treatment, any treatment, when it asked in PACES examination, you have to know first how to start. It's always in the United Kingdom: patient education, patient counseling, and multidisciplinary team management. Once again, I'm repeating: patient education, patient counseling, and MDT. So what are the things you need to educate the patient? First thing, what are the non-pharmacological therapies? Progressive, some exercises, aerobic exercises, balance exercises, some complementary activities like, they are even recommending something like a Tai Chi, some dance and stuff. There is a water-based therapy to improve balance, gait specific training, other physiotherapy programs they can do. Then coming to pharmacological treatment, you all know that, right? Carbidopa, levodopa, then you can give a dopamine agonist, amantadine, trifenoxidil if they know tremor is not responding. All right. And then latest modalities, you can even use subcutaneous apomorphine, and there is a duodopa jelly delivery system directly into your intestine. And even you have this deep brain stimulation. All right, now it's the latest topic now. A lot of people are trying with that. Yeah.
Okay. So, doctor, what are the emerging therapy for Parkinson's now?
Okay. There are certain therapies that are typically emerging for Parkinson's disease. The very first thing is there is a GLP-1 agonist we all know, exenatide. All right. It has shown some motor improvement in Parkinson's. Then there is a transcranial magnetic stimulation, which we can do. All right. There is a trial going for tissue cell-based therapy called TransNeuro trial. All right. They are investigating dopaminergic cell replacement therapies. All right. Whether they can graft a fetal tissue into the brains of the patients. Then there is a gene therapy. There's always a gene therapy for a lot of things. All right. Then there is an immunotherapy targeting alpha synuclein. It's going on. Then there is a glutamate receptor modulator. All right. It has received orphan drug designation for managing levodopa induced dyskinesia. The question has been asked once: do you know any latest drug for that? The drug is dipraglurant, Dipraglurant. That's one of the latest drug for Parkinson's disease. Beyond that, a candidate should know what are the surgical options. Can do a thalamotomy, can do palidotomy, subthalamotomy, deep brain stimulation, transplantation. Like I said, transplantation is something that can be also tried. I mean, like Niagara cell transplantation.
Okay, that was a wonderful discussion on Parkinson's disease. I'm sure that we have covered almost everything that a candidate needs to be aware of to crack the case of Parkinson's disease. We have discussed about the approach, the differences between the Parkinson's and Parkinson's plus, the complications, investigation, management plan, tremor, what to do and what not to do. So thank you so much, doctor. We have we have had a wonderful discussion with you, and it's a pleasure to have you back again with our every other topic that we keep on discussing, and we make sure that we make it much more simplified and fun for all our candidates.
Thank you. Thank you so much. And I hope to see you again and see you all again with another topic in neurology. And also, soon we are going to have a couple of other consultants and other trainees in the respective specialty going to come over, and they're going to discuss a lot of topics which you need to know for your MRCP UK PACES examination. Enjoy our podcast and do visit our website and our YouTube channel. Thank you so much.
Thank you once again, Doctor, and we'll be meeting you in our next session with another important topic to dissect. So now you all can listen to various topics in neurology and keep revising them whenever and wherever you want. Please visit pacesdiaries.uk and listen to our podcast series. Thank you and see you again. Bye.
Thank you. Thank you so much, Doctor.